Assessing a child at the front door is no easy task. Hopefully, with the help of this video and the PD team, we can ease the concerns you might have in quickly assessing a child and transferring them to the most appropriate area in the department. First of all, look at the child. Are they cyanosed? This may be hard to spot. Look around or on the inside of the lips, hands or feet. Do they have excess secretion? Listen to the child. If they're talking, laughing, great. If you hear crying, also great, because it means the airway is bathing. Two noises we don't want to hear are stridor and gargling due to excessive secretions. If a baby presents at the front door, feel free to pick them up. Check for tone. Are they limp or floppy? Or are they restless and trying to get back to mom? We want to act quickly on children with an airway problem as they are peri-arrest. If not treated, they can quickly deteriorate further due to some anatomical differences. Children have larger heads, resulting in extra strain on the neck, larger tongues, which occlude more of their oral cavity, and a conical shaped airway, that means it's narrower at the bottom than at the top. All of these result in trickier intubations. Red flags are reduced tone and stridors. An unwell-limbed child cannot protect their own airway. Stridor can happen for different reasons in children. It could be because of croup, or because of inhaling a foreign body, or because of an acute allergic reaction. These children need to be in recess. If an adult was unrousable presented in the front door, or if they were having stridor at rest, they'd immediately be sent to recess. This is exactly the same for children. Looking and listening are the tools we use to assess breathing at the front door. Firstly, and most importantly, look at the chest. Is there bilateral chest rise and fall? Are there retraction? Does the child look tired? Then listen. Don't worry, you don't need to auscultate at the front door. In some children though, you can hear a wheeze even without one. But these children might need resus and a rat assessment. 3 things to consider when assessing a child's breathing are: rate, how fast are they breathing? Recessions, if there are any, where? Rest, do they look tired? Peds breathe differently from adults, in some ways at least. Number 1, obviously, is that it's faster. The smaller the child, the faster the respiratory rate. Under 1 month old can be breathing 1 full inhalation and expiration in 1 second. And children's chests are more pliable due to the nature of their muscles being underdeveloped. This means that they have more ability to suck in to expand their chest cavity. Their favorite places are in between the ribs, under the chest, and in the front of the neck. If a child has sternal recession or tracheal tug, is grey in color, or starts to look very tired, they need resus. If you're unsure, it's better to move them to resus to be seen by a doctor. Children have smaller circulating volume than adults, and this means they lose fluid quicker. For example, a child with DMV could potentially be life-threatening due to how much they're losing. If you assess a child with symptoms of dehydration, give peds a call so triage can be prioritized. Fever in under 3 months old, mottling of the skin, reduced capillary refill time are big red flags. At the front door, I wouldn't expect you to do a GCS on every child. However, if a child comes in with a reduced AFPU, it is essential that you escalate them to resus. Any deviation from the norm is a worrying sign in neurology. Ask the parent, is this normal for them? Consider if they have any learning difficulty or are they neurodivergent? Is this a new onset of deteriorating AFPU? Red flags in disabilities are irritable child, high-pitched sound cry, responsive to voice or less, poor tone, floppy, or actively seizing. Children enjoy to share germs with each other. They have little to no concept of social distance, which results in illnesses going around like wildfire. Coughs, fevers, rashes are commonplace. However, there are 3 red flags we need to be aware of whilst assessing them. Look at the rash. Is there a line of demarcation? A distinct line that separates the erythema from the rest of the skin? Is it a non-blanching rash? One that doesn't go away when you apply pressure on it? These, combined with fever, reduced GCS, and a new onset of irritability, could be a sign of meningitis. Fever in neonates, and in general under 3 months old. will be treated for sepsis due to their limited ability to fight infections. Their immune system is so new, even a small infection can cause them to become seriously unwell. We hope this video helps you understanding how to assess a child at the front door. And if you need anything, you can always come to the PD team.